you all here, and whoever may be online or coming online, because no one can be slow to join. I am so pleased here to introduce two of our wonderful members of CPC. Well, members and members to be.
I'm an adjunct member.
Adjunct member and mentored member to be. So Ryan Marker started out as a mentored member in our program. He's an assistant professor in the Department of PM&R. He has been promoted to full membership at the Cancer Center, the recent funding of his R01 that I hope he's going to talk about today. In addition, he serves as the liaison between CPC and our work liaisoning with our community outreach and engagement, our excellent EAS, which
engagement,
success,
and success,
and Surtech. So we're glad to have it. And then I think these, two wonderful people represent such a great example of the collaboration that we're trying to build within our program, bringing in postdoctoral students that are going to be moving up within our program to their own research programs. It's really exciting and amazing. And your group in general is just such an emblem of success. So I'm going to turn it over to you all. And Emily didn't fully introduce you, sorry. Adjunct member, postdoctoral on a K99 R00. So we know, assuming we still have a research infrastructure in a year or two, there's so many
currently on the job market. So please maintain your infrastructure.
This is all we want to do.
All right, thanks, Stacy. So, I'm Ryan Marker from PM&R. Primarily live at the Health and Wellness Center, where I direct the B50 Well Cancer Exercise Program, which you'll learn about here. So I'm just going to get us going. The title here will hopefully make more and more sense as we move through the presentation. We don't have any conflicts of interest to go over. So, presenting an overview of what Emily and I are going to talk about and present today is, so the existing infrastructure that's referred to in the title is the B50 Well Cancer Exercise Program. So to start off, I'm going to give us just a brief overview of that program so everyone's familiar with how it's being leveraged throughout the presentation. I'll move into the first example of adapting and using that infrastructure to adapt and develop enhanced programming, where I'll go through my work developing a telehealth exercise program for rural survivors, which eventually led to, I'll present the pilot results that led to the R01 that Stacy mentioned. Then I'll hand it over to Emily to talk about her work developing a nutrition component integrated into B50 Well with the amazing name of B50 Well. But in addition to these specific points, I don't think it would be a Cancer Center talk if someone didn't say the word cross-cutting. So really, we want to make sure to highlight two cross-cutting themes throughout this presentation. One being the benefits of partnering with an existing clinical infrastructure, and then the other one being the ability to have an overlap between excellence and access in creating lifestyle programming. So just keep those in mind and we'll refer back to those as we go through. Okay, so quickly going through B50 Well, cancer exercise program at the Health and Wellness Center, jointly supported by the Health and Wellness Center and funded by the Cancer Center and UC Health. Here's all of our social and contact information. Before I even get into the program, I always try to flip the script and acknowledge the team because this is the absolute best team I have ever worked with. So, and I'll embarrass them a little bit because I try to include active pictures showing us walking the talk. You know what I mean. So we have Nicole, who's been with the program the longest, even more than me, since it was founded, and she's our program manager. Jared, I call him our research manager, but basically if we get a project up and going, he's the one that actually makes sure it can get done. Leah O'Connor is our amazing program coordinator. Felipe Leon and Hallie Murphy are our amazing trainers. Felipe leads a lot of our outreach work with Latino survivor population. And then just starting with us is Jake Dawson, a master's student up at CSU, who's working on the R01. Be Fit Be Well is a 3-month exercise program, and the exercise content is tailored to the individual. So overall, we do integrate and follow national exercise recommendations for cancer survivors, but these tend to be pretty broad. And so within those guidelines and recommendations, we are able to highly tailor the program and the content for the individual. Everything's developed and led by our cancer exercise specialists. Fairly intensive program, primarily due to that funding that we received from the Cancer Center in the hospital. So participants receive 1 to 2 one-on-one 50-minute exercise training sessions a week during the first month of the program. And then that continues in the second and third month of the program, but they just move into small groups of potentially up to four patients. They're still all doing their individualized exercise programming. It's just one trainer supervising up to 4 folks. Recently, over the last couple of years, we've integrated additional support for unsupervised sessions through a personal training application that's available for free to our participants. And we've integrated telehealth and hybrid programming with video conferencing, which definitely plays into the rural work. We try to keep eligibility broad to increase access to the program, but also try to acknowledge our limited capacity. So the main eligibility criteria we have is folks are eligible if they're either currently receiving treatment or within 6 months of completing treatment. So we try to focus on that more acute stage of survivorship. All cancer diagnoses are eligible. Participants only pay $59 a month for the program. The true cost of the program is actually closer to $1,600 or $1,800 if you look at the standard rates for personal training sessions. Primarily, this is there to facilitate adherence. When the program started, it was free for everyone, and there was a lot of poor adherence and attendance. And so by having this cost, it increases skin in the game. But if anyone identifies financial hardships, we have reduced and fully subsidized memberships available as well. All right, so super broad overview of BFIT. Please feel free to reach out to me if you have any more questions on the program. But ending from BFIT, where we are at right now with the program is we've developed and are really trying to follow through with this mission of providing excellent and inclusive fitness and wellness services to survivors at the Cancer Center and surrounding areas. And I really try to use this to guide the research and the work that we do, focusing a lot on these 2 words of excellence and inclusive, and I interchange that with access sometimes. But I feel like when people talk about lifestyle programs like exercise, where it's not typically reimbursed, if someone says that they want an excellent program, or if they want an accessible program, those are viewed as mutually exclusive. If someone says they want an excellent program, people are like, okay, we need to build them the Cadillac of the program, like how much service can we provide for them, how much can we give them, because it's trying to increase the value as people typically need to pay out of pocket for that. Whereas once we talk about access, we're like, okay, what can we cut down? Like, what is the bare minimum we can include? And really, I think that the work that both I'm going to present and Emily is going to present is going to show that done appropriately and with this in mind, you can actually advance both the excellence and the accessibility of these lifestyle programs. Okay, so I'm going to move into my specific work. So showing an example of starting with this clinical exercise program and using that to build this research program in telehealth exercise for rural survivors. It really started from 2 questions. One is we started to think about how do we improve the individual responses to the exercise program. So, and I'll show an example later, but usually benefits of programs like this are presented as population averages, but I think most of us know that no patient is the average patient. So can we do more to make sure that each patient responds well? And then separate from that is how do we adapt and increase access for rural Colorado? As collaborators and I were meeting, we regularly identified it. Even if you live in Denver, it can be hard to get to this campus And so we've always had this drive to try to develop some sort of telehealth programming, but we wanted to make sure that we would do it well. In Colorado, being known for exercise and having a large rural population, we thought this was a good place to do this work. So going to the excellence piece, how do we increase the individual responsiveness of participants? Specifically, I started focusing on cancer-related fatigue as a very common symptom across many cancer types and treatment regimens, and it is also very functionally limiting. So it's often reported by patients as the factor that's keeping them from returning to their normal life. And it's more than just physical fatigue. So you can see the definition here where it includes a sense of physical, emotional, and cognitive tiredness that's not proportional to what's been done. And exercise is known to be one of the best interventions for cancer-related fatigue. There are actually reviews that when compared to medical interventions for fatigue, exercise performs just as well, if not better. And this is data. This is from a publication that used BFIT Be Well data. Presented typically, we're translating the benefits that have been seen in the standardized, in the controlled research trials that have shown that exercise can improve cancer-related fatigue. So here we see just a pre-post score in cancer-related fatigue from our clinical population. For this specific measure, an increase in the score represents a decrease in fatigue, and we see a large and significant improvement in fatigue. However, when we start to look at individual responses and when we try to identify what a meaningful response would be, we actually see, despite that large and significant improvement at the population level, 42% of our participants actually don't achieve a meaningful improvement in fatigue. So how can we address that? So the strategy that we adopted to try to address that is developing a tool to better guide intra-program adaptations. So individual responses to exercise are highly variable, influenced by so many individual factors, trainer factors, life factors, all of that. So we wanted to figure out, okay, can we figure out a way of knowing when we need to change our intervention or adapt it to improve their response to fatigue. So we collected fatigue surveys from BFIT Be Well participants, not just before and after the program, but every 2 weeks during the program for 2 years. Ended up with a sample of 173 folks with an average of 4 fatigue time points each. And what we were able to do is come up with this reference chart that for any of you with kiddos are familiar with growth charts for kids, this is the exact same thing. So whereas on growth charts for kids, you want to, if when they're born, they're at the 50th percentile of weight, physicians want to make sure they stay and track at that 50th percentile as they grow. And if they don't, it's an indication that something needs to be done. And the same can be done with this reference chart, where you can see the different percentiles of incoming fatigue scores of participants into the program and their predicted trajectories based on that initial score. And so this will come back in later, but this was a tool that can be used to inform a trainer about whether a participant's fatigue is improving as expected in response to the exercise program, or if they need to change something. And then looking at the second question of improving access for rural participants, the initial response there is okay, look, you can start to do telehealth, do video conferencing. This was all before the pandemic. I submitted the pilot application the day before everything shut down, and I'm sure that probably was on the reviewers' minds, and so I'm okay with that. Hopefully it's led to something good. But even then, we're it's not going to be the same. We can't just directly translate, okay, instead of having the in-person session, we're just going to do it via Zoom. We knew that there were going to be differences. And that's supported by the literature as well, where supervised exercise programs, so those done in person, regularly outperform unsupervised programs in terms of improving cancer-related fatigue. And it's these unsupervised programs, that's kind of the typical program that's been available for rural survivors. It's scalable, they don't need to come in, but those are likely not having the same benefits. And then in addition to that, the literature shows other unique barriers to rural survivors participating in exercise programs. So transportation and availability, that ties into the geographic disparities, but also just awareness of programs. Flexibility of programs is something that I like to highlight. I don't think people realize even if an individual living in a rural area is retired, if you're living rurally, there is always something to do. There's always something going wrong at your house that you need to maintain. And so there's a need for increased program flexibility. They struggle if a program's like, okay, Wednesdays at 5, you need to do this. As well as lacking access to a knowledgeable exercise provider. A lot of folks have heard that exercise is good for them, but they don't know what's safe and they don't know how to start. So taking all of these factors, we did kind of an old school approach to adapting the program where we just kind of sat down as a team and came up with this. But here is what we developed as the Be Fit Be Well telehealth program. So we rely on three primary tools that we try. There's always the balance between the tech divide and efficiency of a program. So we try to keep these as accessible as possible. So we use Zoom for all of our live telehealth sessions, and most people are familiar and comfortable with Zoom right now. We do use a commercial personal training smartphone application, but it's free to participants. It has a very simple user interface, and it's also available via a web browser. So if a participant doesn't have a smartphone or doesn't want to use a smartphone, a lot of our older participants have just used their computer to access it. And then we do regular scheduled email surveys. We use Redcap, but lots of different services could provide automated surveys. Assessments, we kind of did the direct translation. So we translated the initial physical assessments from Be Fit Be Well to be performed safely and to be performed well via telehealth. And we do that before and after the program. But one of the first adaptations we made is instead of doing one telehealth session per week to mirror the 1 to 2 supervised sessions per week in the Be Fit program, we dropped that down to just 2. Like, we knew that it's important. They need to have that time, that live interaction with a trainer, but they don't necessarily need it every week. And if you schedule it every week, that reduces the flexibility of the program. So instead, we translated a lot of the exercise prescription to this personal training application. And I've started to refer to this as asynchronous supervised exercise because it is still highly individualized to the patient. We're not giving them stock exercise recordings. We are prescribing each exercise, the number of repetitions, the number of sets, the order of the sets. Each exercise has an embedded video of our trainers demonstrating it. And most importantly, is it facilitates easy text communication between the patient and the trainer. So either in regards to a specific exercise or to the session as a whole. So one of my favorite examples from our pilot was a lady who says, like, she was prescribed forward lunges in her exercise program and they hurt her knee. But in the interview afterwards, she was like, but it was fine because I knew I could just text Ian in the app, who is our primary trainer on this, and then he would see it and adapt all of her sessions going forward. And then finally, to integrate an effort to improve individual responses, this is where we included the reference chart by integrating regular symptom monitoring and symptom triggered sessions. So we send individuals the fatigue surveys every 2 weeks during the program and then plot that on our reference chart. If individuals are not tracking as expected on the chart, then that triggers an additional telehealth session for the trainer to have a discussion with the participant about what's working, what might not be working, and then make adaptations to potentially improve the response to the program. So now we'll go into the results of our feasibility trial of this telehealth program, which was funded by the Cancer League of Colorado. Our initial goal here was to create the telehealth program specific to rural survivors with cancer-related fatigue and attempting to replicate the benefits, the superior benefits of a supervised program. Aim 1 was assessing various feasibility metrics of the program and the pilot, and Aim 2 was doing a more qualitative assessment of participant perspectives and experiences in the program. So in terms of feasibility, recruitment was our initial learning curve, where it proved much more difficult than we thought, which it always does. But eventually we ended up one participant short of our goal of 20 participants. So we recruited 19 participants, 15 of them completed the program. And when we had figured out recruitment and we had funds to have all of our mechanisms in place, we had a decent recruitment rate of 5 new participants per month. Our data collection, for the most part, proved to be very feasible and successful. We tried to do a 3-minute step test and measure heart rate virtually, and that too many issues came up there. So we're adapting that going forward, but everything else worked well, and completion rates of our intra-program fatigue surveys were very, very high at 94%. And then attendance was also really good, where those week 1 and week 6 telehealth sessions, almost 100% attendance, the triggered telehealth sessions, still really high attendance, and a really good self-report completion rate of the asynchronous sessions delivered by the personal training application. One thing I think it is that I do like to note here is, we had 19 participants recruited, 15 complete. Only 3 of those 4 participants who didn't complete the program, they didn't make it to starting the exercise program. So there was an unrelated medical event. One participant withdrew because they just decided they didn't have the scheduling capacity. And another learning experience for us is I withdrew one participant from observing unreported balance deficits during her initial assessment. And as a PT, I wasn't comfortable with her doing virtual exercise, and we connected her with a local clinic. And then the one participant who was in the exercise program but didn't complete had an unrelated medical surgery come up. So I highlight that because no participants in this small pilot at least dropped out for a reason that could be directly tied to their experience in the program. Moving on to a preliminary evaluation of participant responses. Here's our primary outcomes, classically presented at that group level, with primary outcome of fatigue. Again, we see a very significant, large improvement there. In terms of our secondary outcomes of physical function from our assessment, we see trends towards improvements there that are probably limited by the small sample size here. But getting to that question of individual responses, now we're looking at the individual changes of each participant who completed the program. And we see a really good response rate. So we can see that the MCID, so the minimal clinically important difference, 13 of our 15 completing participants experienced at least that minimal clinically important difference in fatigue. So 13 of 15 experienced what would be considered a meaningful response, a meaningful improvement in fatigue. If we dive even deeper into the individual data, so instead of just looking at changes across the program, now we're looking at the data from those intra-program fatigue surveys. One really interesting finding here that I didn't expect is that half of the participants never triggered an additional session. They improved as predicted with the more minimal program delivery method, like much more asynchronous delivery than in our supervised program. And in the participants who did trigger an additional session, very small sample size, but anecdotally, you can see that following the majority of these symptom triggered sessions, there was an observable improvement in fatigue, indicating that symptom-triggered intervention is hopefully having the effect that we wanted it to have. We haven't published this yet. Jamie, eventually I will talk to you and we will get this published, because we worked with Population Health Shared Resource Service, right? Yeah. To do our qualitative analysis. Thank you so much, because I do not do qualitative analysis. But we saw a couple of big themes come out from the post-program interviews that we did with participants. One being participants really, the way that we addressed the access to a knowledgeable provider seemed to be really successful. Participants really liked having that easy facilitated communication with our exercise specialists via the application. But that was driven by the fact that they had also met them in the live session. So I do think it's important to have both. Enrollment itself was driven, one, by a desire to benefit themselves and others. So definitely, I think a lot of us probably have experienced this in the survivor population of an increased pay it forward mentality. And we see that as well. And then also, participants regularly described that the program promoted a sense of accountability to improve their adherence, which is something I thought would potentially be risked to be lost, reducing the live interaction with a trainer, as well as their perceived improvements. So potentially maybe the fact that we gave them surveys in addition to fatigue, so it wouldn't be completely clear to them that everything's being driven by the fatigue surveys, but they're regularly reflecting on that still. And so they regularly reported that they saw the improvements in themselves during the program, and this helped to contribute to continued and improved adherence. So that was the pilot that somehow led to our R01 that just got funded in September, where we are doing a fully powered randomized efficacy trial of this intervention. But also trying to take the next step in improving this intervention of examining what could be additional targets to inform those exercise adaptations. So right now, with our reference chart, we know if fatigue is or isn't improving as expected, and then it's up to the trainer's experience, knowledge, and the art of training to decide what adaptations to make. If we can get more granular in the responses to the program, perhaps we can inform what those adaptations should be. So here's the overall structure of the study. So again, based around this randomized efficacy trial, with participants in the waitlist control moving directly into the intervention. So everyone who joins the study will get the intervention. But aim 2 and 3 is where we start to integrate this investigation into additional responses. And probably the most exciting there is the integration of remotely collected dried blood spots to perform metabolomic analyses on. So again, here's an example of that excellence and access coming together, where we're able to do state-of-the-art analyses to help to potentially inform the exercise prescription using an accessible means for rural survivors with these remotely collected dried blood spots. I'm not going to dive into metabolomics, but here's just an example of what drove our initial hypothesis here with Travis Nemkov, a part of the Cancer Center's mass spec metabolomics core, has done work with elite athletes, and then a project in long COVID where both in elite athletes, after a fatiguing task, demonstrated a certain profile indicating impaired fatty acid oxidation. And that was also seen in patients with long COVID compared to those without long COVID, where fatigue is one of the most common symptoms. So together we took this and made the hypothesis that this impairment in fatty acid oxidation could be a common metabolic profile of fatigue, which is easily and directly addressable by adaptations in exercise prescriptions. This is an example of the patient-centric devices that we use to do these collections. This is the final exploratory aim is looking at a dynamic response. So in a subset of folks who are able to come in, we'll be looking at their dynamic metabolic responses to exercise. But that's probably one of the more exciting and novel pieces integrated into the R01. Okay, I went a little 5 minutes over, I apologize, Emily. So again, this was one example of how to leverage an existing infrastructure to promote the development and adaptation of an enhanced lifestyle program meeting patient needs. But like I said, we took a more old school approach to adapting the program, which isn't necessarily bad, where we took what we knew about the population, experiences with the population, and just developed what we thought would be a program, and probably lucked out a little bit in that it did seem to be pretty effective. So moving into another example of how to collaborate with and leverage this BFIT infrastructure in a discipline outside of exercise, I'll turn it over to Emily, who will also provide a good example of a more rigorous development, rigorous process of program development.
Sure. Thank you so much, Ryan, and thank you everyone for being here. I'm very excited. So as Ryan alluded to and Stacy mentioned in my introduction, I am certainly outside of the realm of exercise, and I'm a dietitian by training. And so something that I think a lot about when thinking about survivorship and lifestyle behaviors is, what about nutrition during survivorship? What do we know that might be special about this population that we might want to address? And first and foremost, I'll keep this very brief, but after completion of active cancer therapy, the recommendations for cancer survivors largely mirror that of the general population. So it includes things like following a primarily plant-based dietary pattern, limiting things like alcohol or red and processed meats or sugar-sweetened beverages. And these guidelines for cancer prevention are recommended for survivorship as well. And they're very similar to what you would see from the American Diabetes Association, the American Heart Association, or even the dietary guidelines for Americans. So these are very basic guidelines that we're asking people to follow in order to improve the trajectory of their survivorship, because we know nutrition does matter. However, we also know people aren't really meeting these guidelines, right? And so a recent publication that came out in JAMA Oncology suggests that US cancer survivors are not meeting recommendations for multiple lifestyle behaviors that we know can influence their health. In fact, only 4% are meeting 4 of the most recommended guidelines, and that's body weight, diet, physical activity, and limiting alcohol consumption. And so we know that this group really needs some support to help them to change their lifestyle behaviors. We also know, unfortunately, that brief consultation with a provider, whether it be a dietitian or an exercise physiologist or a primary care physician, does not have a lasting impact on lifestyle behaviors. And so what drives a lot of my research agenda is, how do we help people to modify these behaviors to meet the guidelines that we know can help them to improve their health? And research suggests that in cancer survivors, multiple health behavior change programs, so programs addressing more than one health behavior, not just exercise, but also diet, do lead to improved behaviors overall. And so during my pre-doctoral training at Ohio State, I did a lot of work in this space in developing interventions for cancer survivorship to improve diet and physical activity patterns. And the way that I kind of conceptualize developing a program is in 3 steps. And the first is to really understand the need. So what is it that people need in order to help them improve their behaviors? And what programming might already exist? What infrastructure can we leverage? And so at Ohio State, I had the privilege of working within our James Care for Life Cancer Survivorship Garden called the Garden of Hope. And that was a community-based program where anyone receiving treatment in the central Ohio area could come, harvest fresh fruits and vegetables, and we did focus groups out there after participation. And some of the themes that really emerged from participating in this community program were that, okay, when I'm out there over the summer, I feel like I'm eating more fruits and vegetables. Maybe not surprising. I feel this sense of community and support. My mental health is improved. When the garden ends, I really feel like I'm having some challenges maintaining those dietary changes long term. And so we decided as a team, I certainly wasn't leading it at this point, that we needed to design a program to kind of complement these efforts. And so when thinking about how to design a program, we started to kind of take it back to behavior change theory, right? And what sorts of things can support people in designing these programs. And certainly when it comes to nutrition, there's some level of education that we think might be important, right? People need to know what the guidelines are in order to follow them. They need access, right? And for this case at Ohio State, we had this community garden that might provide a good source of access. they needed support and tools to help them change their behaviors. So integrating things maybe like pedometers for self-monitoring, or asking people to track their diet over time so that they have an idea of what changes they're making and the progress they may or may not be making. And of course, once you design a program and implement it, you want to be able to test and evaluate it. And I don't know how familiar you are with the World Cancer Research Fund, American Institute for Cancer Research, but they have a set of about 10 cancer prevention recommendations that they somewhat recently, this was 2019, operationalized those recommendations so you can actually score someone's adherence. And so I don't know if I have a cursor, and if I do, you probably won't see it anyway. The top blue here that's a little tennis shoe. And so that's operationalizing the recommendation for physical activity. The recommendation is 150 minutes per week of moderate to vigorous physical activity, and cancer survivors, we utilized 7,000 steps per day. You can do the same thing with body weight. So are you meeting the recommendation for waist circumference and body weight, and some different measures of diet as well. And so in the program that we designed at Ohio State, it was a 6-month garden-based behavior change program, integrating some of those different things that I mentioned. And something that I was really interested in is, does participation in this program change adherence to these guidelines? And so this was something that I did just as I was leaving Ohio State to start my postdoc here. Was I took data from people who participated in this program and scored them according to that operationalized score to see if the percentage of people compliant with the guidelines improved after participation in our intervention. And so here you can see each kind of stacked chart represents adherence to a guideline. So the top here is healthy weight. The darker the bar, the more adherent. So each score ranges from not adherent to partially adherent to adherent. And you'll see the bars going from the top bar for each recommendation is pre-intervention. This is just a simple pre-post. Post-intervention is the bar underneath. And you can see the bars get darker as you go down. And so participants reported, greater physical activity, which we measured through pedometers, greater dietary intakes, which we measured through food frequency questionnaires. And we saw some improvements in weight as well. And so this makes me think, okay, this could potentially be an excellent program, right? But how do we design and implement so-called excellent programs within clinical and community settings? Because as wonderful as this program was, I don't think that it's actually been implemented at Ohio State as a clinically accessible program to everyone. The garden still exists, but this was a very finite research study, right? And so something that I think a lot about is, how do we get this out into the community? And we know from the literature that these multiple health behavior change interventions, despite being very effective, are very often not translated to clinical practice. And I recognize that this is a very small screen now, so these purple dots probably mean very little to you. But this is from a scoping review looking at survivorship delivered in the primary care setting. And what are the barriers and what are the potential solutions to getting more survivorship care out into the community, out into private or primary care? And the barriers across the top here, which you can't see, I'm not even sure that I can at this point, were lack of interdisciplinary communication, a lack of awareness of the guidelines, barriers to time. And so the greater the size of the purple dot is, the more that these individual studies in the scoping review reported that as a barrier. And as you go down, these are potential solutions. And I put the arrow across the bottom here because strengthening interdisciplinary communication was the most commonly identified solution to addressing some of these barriers. And, keeping in mind on the right-hand side here is just this idea of how we can, think about implementation of programs. It's not just diffusion of ideas, and it's not just dissemination to a specific group. It's how do we actually get these programs implemented and sustained long-term in order to make sure that more people have access. And so that's where we kind of came up with the title of our talk here. And this is where I'll really shift gears to focus on what I've been doing since being here. And that's leveraging this existing infrastructure that is the Be Fit, Be Well program in order to adapt lifestyle programs for enhanced survivorship. And despite all of the wonderful, wonderful things the Be Fit program does for people, I had looked at some of their research database data that collected information from participants over about 10 years to see were participants in Be Fit, though we know they're improving, fatigue and physical function, were they improving some of the things that I might be interested in as a dietitian? Are we seeing those who are coming in with overweight or obesity improving their BMI? Are people participating in an exercise program improving intakes of recommended food groups like fruits and vegetables? And perhaps not surprising, the answer to that was no. And that led me to start thinking about this 3-step process. What's the need here? And I think, and the data suggests, that nutrition-focused programming for cancer survivorship might be useful. And that's where we started to kind of conceptualize this Be Fed, Be Well program. And the CPC program agreed because they funded the pilot study in order to design and integrate this survivorship nutrition program within the existing Be Fit, Be Well program. And as Ryan mentioned, I took a little bit of a different approach in that I did sit down and think like, oh, what works? What does behavior change theory suggest? But the first aim was really to engage people and ask what their needs were and what might work for them. And so in terms of designing this program, we had one-on-one interviews for human-centered design testing, and I met with 3 different groups. We had 5 people who were providers or oncology experts. So whether that be the lead dietitian at the cancer center, the survivorship care plan coordinator, we met with, and I say we, I met with lifestyle program delivery staff, so people in Be Fit or other providers at the wellness center delivering nutrition programming, as well as previous Be Fit participants who were familiar with what was available in the Be Fit program and what some of the gaps might be. And so from that, we learned a lot about the type of content people would want to be addressed, the messaging, those sorts of things. And then I was able to kind of work backwards and create my conceptual model and do some intervention mapping to think about what types of things could I provide in order to address those content areas of interest, the support that they might need. And so we utilized social cognitive theory in order to create an intervention that was multi-component. So there's an education component to help improve knowledge of the guidelines. There's the counseling with the dietitian to provide that one-on-one support. We had some skills development sessions and cooking demonstrations in order to help give people practice integrating these skills into their lifestyles, as well as group discussion to provide some of that community support, with the idea that we could help people to improve their behaviors, both from the combination of working in this Be Fed, Be Well program for nutrition and the Be Fit, Be Well program for exercise to improve overall adherence to the guidelines. And so that's where we conducted a single-arm feasibility study last summer. We enrolled 11 participants, and they participated in the existing Be Fit, Be Well program as is. So I tried really hard not to touch the existing program because I wanted to leverage that infrastructure and think about what could we potentially add on top or integrate within that would be feasible long-term. And then we delivered the Be Fed program with the core education curriculum, and then those other components that I mentioned, the one-on-one support with the dietitian, the group support was integrated within each weekly session for education. And then we also had the skills development and cooking demonstrations. And then we collected data at baseline, 6 weeks, 12 weeks, and then we had talked to them for 12 weeks, had them come back at 24 weeks for additional assessments. And in the interim, I did another series of one-on-one interviews with not only the people who participated, but also the program delivery staff to think about what might some of the barriers be to implementation long-term. And so in thinking about how we test and evaluate this feasibility study, we're looking within the D&I, Dissemination and Implementation Science Framework, the RE-AIM PRISM framework, which was kind of developed here at Accords. And so thinking about who are we reaching with this population? We screened 78 people to get those 11. Many of the people that we screened were not cancer survivors or did not meet our BMI criteria. So that really indicates that perhaps more targeted advertisement or recruitment of this population might be useful. And similar to what Ryan had said, you know, the people that enrolled, I'll go on and talk a little bit about who stayed in the study, but it was most people. And so the reasons that people weren't able to participate largely reflected, they may have already been meeting recommendations, or perhaps they weren't able to commit to the program itself. And thinking about who we reached, again, we had 11 people, not intentionally, we had all female not breast cancer survivors, but many of them were breast cancer survivors. And so thinking about, though we didn't have a lot of diversity, we did have some differences in SES. And so trying to really think about how we reach different people to enroll in this program, and also thinking about the people who did enroll and what that might mean in terms of how it worked for them or not. Overall, adherence was really great. So coming in, we had 88% mean group attendance over the 12-week sessions. And we had 2 people of our 11 that had perfect attendance at everything. And something that Ryan mentioned is that having some program flexibility is really important. And in this case, we did synchronous Zoom sessions on Wednesday evenings. And so if someone couldn't come or they were traveling, like, yes, they could log in. And we did have a couple of people do that, but some people weren't able to. And so that's something to think about, because attendance for the one-on-one counseling, which was scheduled on an individual basis, at 100% attendance, not a single person missed their individual sessions. In terms of thinking about completion rate for assessments, we asked them to do a lot of things. So I had them complete a bunch of different surveys. They wore active PALs to measure physical activity. We did both food frequency questionnaires and diet records to look at change in diet. And I even had them collect urine and stool samples at home and bring them in. And many people, everyone on study completed their assessments. We had one person that had withdrawn by 3 months, and so she did not come in for her assessment. And then we had a couple of people that didn't come back after that no contact period. And this is kind of the same thing in terms of retention. We had one individual that withdrew for family reasons, that she needed to take care of an ailing parent, and a couple of people that we just kind of lost contact by that 24-week time point because we hadn't been talking to them for 12 weeks. Certainly something that I was interested in is the preliminary efficacy. And so not only are we able to conduct the study, are people coming, but are we improving things like diet and physical activity and body weight? And we did see a significant improvement in dietary intakes and trends toward improvements in some of those other areas. Again, we only had 11 people, so thinking about that moving forward, but it seems like it could be a very effective program. Again, we did these one-on-one interviews to talk about acceptability of the program. So 10 of the 11 participants came and did a one-on-one interview to talk about their experience, and all of the providers in BFED and BFIT also talked about some of the logistics and what could be done better. And similar to Ryan's results from his qualitative work, we had a lot of just appreciation, a lot of feeling like I'm able to really take control of my health. And having this support has been really helpful for me and has really improved my confidence. And so as I start to think about, what's next for BFED Be Well, how do we optimize these interventions to make sure they're both excellent and accessible? So oftentimes when we're thinking about designing a behavior change program, we have this kind of treatment package approach where I say, okay, the education's important, the counseling, all of these things are important. We're going to package them together, put them in this kind of black box intervention. This is our intervention. We're going to test it in an RCT. And if it works, great. But if it doesn't, then what? We don't know if maybe the education was useful, but the counseling actually people didn't really like. Or maybe some of the components were effective, but other ones really weren't. And so what I'm utilizing in this next step in the testing and optimization of the BFED program is the multi-phase optimization strategy, which is a framework born out of engineering, and that you want to optimize along the way. You want to test different combinations of components to see what might be the most efficient and optimized intervention before advancing to that randomized controlled trial. And so there's these kind of phases. There's the preparation phase where you're doing a lot of this preliminary feasibility testing, which was what was funded by the CPC pilot and the data that I presented. And now, as Stacy had mentioned, I'm on an NCI-funded K99 R00. And in the K99 phase, I am conducting a 2x3 factorial pilot trial of the BFED program, where I take that program that I just tested all of the components together to make sure we could do it. I'm going to test them in different combinations. And so we'll see the main effect of counseling versus the main effect of the group support. And we can probably, hopefully, start to identify these patterns of efficacy for what combinations of components might be best in defining our end BFED Be Well program, with the idea that we'll refine the intervention, conduct a fully powered trial, and then by the time we get to efficacy, we're pretty sure that we've got a good package to deliver. So to give you a sense of just what that looks like, I do think that there's some sort of core component of the program that is necessary. So we have a core curriculum that all versions of the BFED Be Well program will have. And then what we're doing is we're kind of turning on and off each of these other components to create 8 different versions of the BFED Be Well program. And so each version will have 8 people. And what we can do with this sort of study design is we can just look at the people that are getting counseling versus not. And that really allows us to utilize the same people to answer questions about the main effects of each component. And they're kind of recycled across conditions to improve our power. And so for example, we can compare the 32 people in my ongoing study that will get counseling versus those who do not, to get the main effect of counseling. And then we can do the same for the skills and the group support and start to see if there's, potentially synergistic effects. We can look at combinations, interactions. And so it's a really efficient way to test this program. And I don't have time to go into the latter portion, but this is kind of my conceptual framework for my entire grant. And then I'm doing this study to test these different versions of Be Fed, Be Well in an ongoing clinical trial. Cohort 1's first education session is tonight. So we had study orientation last week. And the aims for the R00 phase are to incorporate some of the previous work I had done in dietary assessment and in omics integration to predict and evaluate response in order to see, are we able to actually measure changes in diet, which I could stand on this soapbox forever. It's very difficult to measure diet. And can we potentially use some other metrics to predict and evaluate, who's going to respond and what can we intervene on to make more precision nutrition approaches moving forward. And with that, I'll turn it back over to Ryan to wrap it up.
All right, I'll really quickly wrap us up. I'll also take the blame because I went over in my times. Emily was perfect in timing, I went over. Anyways, I just wanted to bring this back up just to tie everything together. So I really hope you leave today knowing more about each of these individual components, and knowing about the BFIT program, our work trying to reach rural survivors, Emily's work trying to integrate nutrition and where we're going with that work, but then also tying back to this, to these cross-cutting themes where I hope that you've seen the benefits of partnering with this existing clinical infrastructure, where we were able to use clinical data to identify what we needed to develop to best help participants, facilitating access to interview past participants, as well as already having the providers and that level of infrastructure there, as well as this overlap of excellence and access. I think both of these, I think efficiency might be one of those key terms. So like with Emily trying to develop that efficient, optimized program, the efficiency is going to improve access, but she's also ensuring that the excellence, the effect is maintained. So I really want to make sure that those points are brought back up. So quickly, we'll go through our acknowledgements here. So these are my acknowledgements. Here are Emily's. And then I didn't skip the active pictures for both of us. This is like progressive overload for any resistance training, resistance exercises out there. I keep doing that push-up as Rainer gets older. Like eventually I might actually have some muscle mass. So, that will bring questions.
Yeah, thank you so much.
This is not an official question, but where are you?
So that is like Eagle. It's on the west side of Rocky Mountain. Yeah. It's like a backpacking. Yeah. It's like pretty quick. It was the first backpacking and probably still only backpacking trip I've done because it's only like
it's like
8
flat.
miles in.
Yeah, it's flat. So I've done it both as like backpacking and as like a day thing. Yeah, but it's gorgeous.
It's so pretty.
Yeah.
Is Eagle?
Lone Eagle Peak.
Lone Eagle Peak. There we are.
Yeah, it's gorgeous.
Yeah.
This is great work, both of you. It's so important to see. I love the factorial design. I've been thinking a lot about those kind of optimization approaches in the psychedelic world of like mine. So I'm really excited to see what you find. And it seems like those are the kind of methods, that efficiency that we need. And then the access and we talked a little bit about this last week at our annual assembly of hospice and palliative medicine, this like stepped approach that like you're catching people when they're not improving and giving them more. And I just like methodologically, bravo to you both.
I completely agree. I think it's fantastic, both of your projects. And it just made me think, since I'm pretty much a population focused researcher, like how to leverage these infrastructures to do a project with LGBTQ folks and see how we can adapt that and to utilize those things because, given everything that's happening, that's going to be, I think, really important over the next 4 years is how do we support this community. So I am going to be sending you both an email saying, what can we do to maybe, build something else on this to reach out to that specific community? Because I think both of those are needs that we see in all survivor populations, but I think it's really crucial for some of these underrepresented, underserved populations. So really great work, though. I loved all of your models, and I'm just writing things down. It's so interesting. So
Thank you.
I have 2 questions. For the telehealth rural program, were participants, like, did they need to have certain type of equipment, or was certain type of equipment provided, especially for things like resistance exercises?
Yeah, absolutely. So we provided, for the exercise intervention, we provided a simple resistance band set, which actually our trainers have had pretty good experience. They're pretty cheap, but they seem to be working pretty well. Our trainers are also really creative in using what's available in the house, so like loading up a backpack with books. And we always interview participants on what they have available. So if someone has a local rec center in their rural area that they have a membership to, our trainers will utilize that. The only thing they're required to have is a normal chair that's not on wheels.
Okay, that makes sense. And then so I've looked a lot at like the use of survivorship care plans and then kind of tracking, I guess, healthcare utilization among cancer survivors. So have these, I guess, is there like a component for like physical activity or diet that is already part of the survivorship care plans, or is that something that's like completely separate for the patients?
Physical activity is one box that can be checked in the National Survivorship Guidelines. Is diet in there?
I think diet is in there, but I think a lot of the focus in, and you would know this better than I, is in like follow-up, right? And in like maintaining, it's like you need to, and
like
so
coming in and
it's like coming and getting your scans. Like it's not, diet and physical activity is, important for survivorship, but it's not always the focus, right? And so I think, in talking with like Carlin, who does the survivorship care plans here, I think she's like, we refer to Be Fit. Or like, she's like, it's great that now I can tell people about the Be Fit study, even if it's not like a clinical program yet. And so I think there's a recognized need for integrating that into survivorship care plans, but I don't know that it's standardized in the way of like, you should do this at 3 months, at 6 months.
I'm gonna jump in really quick, just to throw out one of my like soapbox pie in the sky ideas is like, I always look for win-wins. And so having the like physical activity or the nutrition intervention, technically is just checking one box in the survivorship guidelines. But I think an integrated system could really like, support for that, say, physical activity intervention, that could then help check the boxes for follow-up measures because they're spending more time with the exercise trainers, and the trainers can help to facilitate, improved adherence to other components. So I love the idea in the future of trying to like really create a much more integrated survivorship program and really leveraging the interaction the increased interaction that folks get in the lifestyle types of programs that they don't necessarily get in others.
I'll hop on a quick soapbox as well, and that's reimbursement for nutrition services in a variety of disease states. So right now, like getting insurance reimbursement, like the dietitians here don't bill, they're just part of standard of care because they don't submit for reimbursement for services. We've talked about that, like this wasn't part of the presentation, in terms of making this a sustainable program. How are we going to make money off of it? How are we going to, the dietitians at the cancer center don't bill. So we could reduce their clinical workloads. They could help to support the Be Fed program, but thinking about that too is also just an important caveat, I think, in this particular healthcare environment that we're in.
To really show this like later ROI sort of.
And I did some work at Ohio State looking at inadequate coverage in cancer centers from dietitians, like the like patient to dietitian ratio. I don't know what it's like for like PT or exercise, but it's pretty abysmal in most cancer centers. It's like 1 to 2,500 or something. We're better here than like most cancers, like comprehensive cancer centers are, but nationwide not so great.
We had that same problem at UNM. And so I love that idea about integrating all of these things and wonder for the other lifestyle component, is someone doing mindfulness or Tai Chi or yoga as the kind of third
Yeah.
side?
I'm
of
trying
that?
to coerce Lauren's.
We're gonna rope her in. We got a big program grant idea.
No, so the Wellness Center has always talked about, they don't do a good job of necessarily advertising and promoting it, but it was technically founded on 3 pillars of wellness, physical activity, mental well-being, and nutrition. And so I've, like, my goal in the future, I've always latched onto that, and I would love to have a program that's more comprehensively centered around those 3 pillars.
That's so exciting.
Yeah. Sorry. What can the Cancer Center do to help the flow of our patient population into your research and or clinical operations?
I think in the end, it all comes down to recruitment. So just easier. I mean, recruitment's the big answer. The more specifics I would say would be better and more facilitated integration into the internal recruitment infrastructure that already exists in the Cancer Center. So they're very good. They've got their teams that are very good at getting folks into clinical trials and all of that. So what Emily didn't mention is, her work's awesome in that it provided the infrastructure for the foundational nutrition infrastructure for another RO1 that's utilizing BFIT, led by Peter Calvos, Vicky Catanacci, and Paul Clean. And when that was experiencing recruitment issues, Peter was just like, oh, like, we've got all the recruitment there. All you need to do is, send someone over to the Cancer Center, to the clinic, and like, they'll get it. And it didn't work because they were outsiders. So just the mechanisms are there, but they're very focused on the other clinical trials. And so just facilitated integration into that system, I think, would be one first step.
Have either of you used the Recruit platform?
It's where we get most of our people from my K99. I tried, Comerb approved it, but UC Health did not, to create a dot phrase for physicians and to put in their after visit summaries. That was an idea that Vicky had as a clinician. She's like, oh, this would be great for recruitment because I don't want to find a flyer and tell a play, but like, if I can just do a dot phrase, put it in their after visit summary, like, this could be a good program. But UC Health wants everything going through Recruit, which has been wonderful, but kind of lacks a little bit of that,
Direct provider
Yeah.
saying this would
Yes.
be good for you.
Yes.
Yeah,
Oh,
which would double what they're getting.
and
instantly.
allow potentially for more, like, especially with trust. I think you should go back to them, show them your data, with the somewhat of the lack of enough diversity, and push.
Yeah.
And we can help. We'll help you
I would
advocate,
that,
because I think that should be pushed.
It's like, what should be the trigger or triggers for referral to your programs? When do you want that to occur? And
It's a really interesting and complex question. So I'll speak for exercise, and I think data is probably similar for nutrition, where exercise has been shown to be broadly safe and effective for participants, for patients across all stages of survivorship. So, in the ideal world, it would be as soon as they come here. However, incorporating the context, that would flood our capacity. We wouldn't be able to work with all of those folks. So in trying to improve that type of stuff, there needs to be a balance between what referral mechanisms we open up and what the capacity of the program is. And then there's the issue of, okay, what then is the appropriate program? So exercise for individuals undergoing intensive treatment that can help them, decrease, they won't fall as far. So then hopefully they come back easier. But are we still giving everyone a 3-month program? So if someone's referred at the beginning of treatment, they get 3 months and then they stop here and then we can't help them get back to where they start. So then it's also a question of what is the appropriate, allocation of our resources of a program? How do we determine what an appropriate dose or duration of a program for each patient is? So it, in the ideal world, it could help anyone at most points, but.
Yeah, that's kind of what I was familiar with in the literature, or my superficial knowledge of it. So my mental idea was that it might be better, or it might be safer for the clinician to trigger referrals during treatment. And if they were, but then there's an automatic referral somehow that comes at the end of treatment. Or when, and that, to make this, as part of the survivorship care plan process.
When that box is
But not
checked,
just
yeah.
the survivorship care plan thing, that, a recommendation from the clinician, or some kind of trigger that lets them know this is a perfect time for you to join this program.
Yeah, and I think right now, like Carlin has our flyers, so folks get exposed to the flyers, but something that's a bit more direct, potentially coming from a trusted provider, absolutely would carry more weight.
Right. I'd rather, Carlin's fantastic. I love her, but I'd like to have her be the icing on the cake.
Yeah.
To kind of close the deal if they hear it from, because we know that folks are more likely to do something when they hear from multiple clinicians that it's a good idea. So if their surgeon is signing off for their care and they're working toward, just follow-up visits, and then the same thing has happened with their medical oncologist and they get the offer there, whether it's electronic or in person, and then, when they're reaching that phase and Carlin's has the opportunity to deliver them a survivorship care plan that's included in that and highlighted, it's like, that's a, trifecta of support and nudging that to normalize that as part of the survivorship care process.
I love I've talked to you about this before, Jamie. I love the idea of an integrated survivorship programming where it would help to facilitate both recruitment to studies associated with it, but also patients getting the service that they need. So if BFIT was a component of a more comprehensive survivorship network here, our trainers are familiar with what other services, so they can be that additional nudge of oh, hey, maybe you can go see Lauren, hopefully, for some mental health stuff, and vice versa. So just a highly integrated, collaborative team of services, I think is a win-win. We'd get more people into the programs, into the research studies, and the patients would get improved access, improved awareness of what's available to them.
So maybe what needs to be done is a kind of separate health services project that actually looks at that phase at at the end of care with the providers, and then the survivorship care plan, and then the integration into the other, we did something similar or tried to at UNM. I think it could be really effective here because they do have this. MD Anderson is a fully integrated system, and granted they have different resources than we do, but we know that it works when it can be done. And the SCP should be part of it instead of just this rote thing that they print out that is do this,
Yeah, so we're actually I've been working with Carlin putting together a database essentially of cancer survivors. So as soon as we ask them to create a special box where their treatment is done, and that becomes their sign-off date for the survivorship care plan. And so once that's populated, they now essentially go into our database, and then we our unit dedicated resource with Compass, they pull data on a certain basis to essentially look at certain visits, so follow-up oncology visits, primary care visits, and then different labs, and then are they up to date with screening? And so I think the more data points or different groups we can work in developing that, I think that could be really great.
And that also presents
No worries.
that it presents really interesting just logistical challenges, and because BFIT's not in the EMR. So like if
Yeah.
you do those polls, you're not gonna get BFIT data.
Yeah,
And then I'm learning more. We have another project going on with referrals. I'm learning that, technically the BFIT program shouldn't have an official referral within Epic because it's not a reimbursable service. So now we're developing our plan to shift towards, not the official referral, but having providers, just send us a message in our Epic inbox and how we can facilitate that. So just like when you get into the insurance and how that plays into the EMR, I mean, yeah, because I want to, and then also on my team, it's like I don't want to double my team's documentation work necessarily if they are able to get into Epic. So it's all those logistical things, but absolutely something to strive for. Not saying we have to strive for.
I think just quickly from the BFED side of things, while nutrition is also important throughout the entire trajectory of diagnosis to treatment to survivorship, the needs are quite different at each stage. And while, as Ryan mentioned, like BFIT is almost entirely individualized. You might have some like group supervision, but everyone has their own plan. And the way that we've conceptualized BFIT is there's like a group-based component, like group education. And so what I envision is kind of different versions of the best version of BFIT. So I'm starting in the post-treatment space where I feel like people really lose contact with their primary team, that they've been followed throughout treatment, and they're like, now what? Like, I'm done, and I don't like, I'm gonna turn to the internet, I'm gonna turn to this influencer on, TikTok or whatever it might be. And like, it's a dangerous place for nutrition information. And so we're creating this like post-treatment program now, and primarily that was from talking with the dietitians at the cancer center that are like, well, we are supposed to be seeing people during treatment, if they need us. So perhaps don't focus your efforts there first. But I can see a BFED version that is for on treatment or for different cancer types or for AYA versus older adults, there's, I think once we find kind of this like optimized version, we then go back to the drawing board, not fully, but, optimize for a different population. So
I'm saying pie in the sky multiple times because I'd go even farther. My like super long-term goal is I would love to have a menu of survivorship options and a shared decision-making tool for each survivor to collaboratively develop their own individual. Because you talk about group, lots of people say like, oh, you need the group, exercise sessions. The group dynamic is huge. Heather Leach up at CSU, like a lot of her stuff revolves around that group dynamic. I regularly work with BFIT, like some of our rural folks are like, hey, where's the group part? I wanted to meet people. And some were like, I love doing this on my, like, they don't want to work in group. And so.
We actually convened a group of survivors and did 2 years during COVID of just interviews, like, what would you want, help us. And actually we came up with, they asked for that exact thing. And we called it the Chipotle method because that's what they wanted. They wanted to be able to choose their black beans and whatever, but that's exactly what survivors want, is to be able, because all of their needs change. Over that 5-year period of survivorship, their needs radically change, right? So they want to be able to even adjust what it is that they're getting. And, so.
And having the provider involved in that. So again, Emily's stuff is great because providers regularly refer to BFIT, telling patients that they want them to lose weight. So they're referring them to an exercise program. Patients regularly come to us and it's like, oh, I want to exercise because I want to lose weight. Pragmatically, evidence shows that in the real world, exercise alone is not an effective weight loss intervention. For some people it works, but for the majority of people, it just doesn't work. So you need the nutrition. So I have been wanting this nutrition component for years.
Yeah, this wasn't my brainchild, I know. I'm standing on the shoulders of giants here. But...
Wait, right.
Science is incremental.
Just a very quick, simple question from Zoom. Are these programs available to Spanish speakers?
B50, well, we have a whole, so Felipe, who I showed at the beginning, is our bilingual trainer. We work with the Latino Cancer Task Force. We host a Latino survivor support group monthly, and we've started an annual wellness event for Latino survivors. The short answer is yes, we have a bilingual trainer, and that is part of Felipe's job is to facilitate the enrollment of folks.
Not yet for BFET.
Not yet.
It is still too new, but that is something that we would certainly like, in thinking of like the catchment area and the population we serve, like not only translating for different cancer types, but different languages.
I have two questions. So one is like for what you mentioned about the integrative thing. Do you also look at the workplace fitness incentives, something like that? Like the people that they got incentives to do exercise?
So like providing almost like monetary incentives to promote exercise. We haven't done that clinically.
Okay.
That is, and we can go into a whole other thing about the difference between folks who enroll in clinical study versus a research study. So we do provide incentives to promote adherence and completion in the research studies. You know, I'll tie that back to, because I know some work's been done on that, but it's interesting. It's like the carrot or the stick, right? So I guess maybe we should try that to improve adherence instead of making people pay, because you know, we've gone to the other end where we try to promote them promoting a sense of value for the program and having them have skin in the game because they're paying for it, so they want to attend. I don't know what the reverse would be if instead of having them pay for it, we paid them or provided some other incentive.
Okay, that makes sense. And then my second question is about like I think your recruitment for the BFAT is right now they are all females. Do you think that it would be helpful that you also include their caregivers or like their spouse?
I would love to do a caregiver, like a dyadic intervention for caregivers. That's a whole nother area.
Because it seems like maybe it's like typical, or maybe it's like a stereotype thing that a female prepare for the food, but it is like probably something that you would be a problem for your recruitment that to have like males in your sample, because
it can be, and we didn't intentionally recruit females for the
Yeah.
pilot, but our split in cohort 1 for the K99 is actually 60-40, so we had a much better split in male female.
And you interviewed some males.
And we did.
Who gave really good feedback.
Yeah, so I've talked to men and talked to people of you know, different cancer types, right? It's not just like female breast cancer, which is like the ongoing RO1.
It's a common trend that in survivorship at least, and I think probably in other conditions, that women tend to be more open to lifestyle interventions. In exercise, a lot of that's driven. There are a lot of specific studies and programs for breast cancer survivor, but I think there's also just kind of a trend for women being more open to these types of interventions initially.
Too.
Yeah, but how about like include their caregivers or their spouse?
I would love to include caregivers.
Yeah.
Thank you.
Thank you. Well over time. Thank you. Very stimulating.